Today, 57 million people in the United States, 1 in 5 Americans, cannot see a doctor when they need to. Lack of access to a primary care provider is a national problem, but those who are most impacted are people who are low income, minorities, seniors, and people who live in rural communities, whether it's Vermont or Wyoming. As we've seen time and time again with dental care, mental health, and other health care issues, the groups that need health care the most are the least likely to receive it. The good news is that just 11 months from now, we will be providing health insurance to 30 million more Americans through the Affordable Care Act. The bad news is that we don't know how we are going to be providing primary health care to those Americans who now will have health insurance.
The issue of improving access to primary care services and aligning our health care workforce is one that's important to all of us, but one that's especially significant given the obstacles that people face in Wyoming. There are serious access challenges in Wyoming that require creative solutions to resolve. We have one hospital that's served by a physician that every time we lose that physician, the hospital closes.
I am very interested in the question about how we equalize access for all of our citizens, and particularly interested in the question about how we make the right investments to lower the overall cost of health care. I think the chairman said it best when he said what we're looking for is better outcomes at lower costs, and that is the peculiar role that the federal government can make if it makes the right upfront investment.
One of the things that I hope that we'll hear some elaboration on is the lifestyle for primary care practitioners. Things like the differences between the amount of time that somebody might be on call as a specialist versus a primary care physician. As we look at larger payment reforms, how the flexibility in their practice of being able to spend the adequate time with a patient, for example, with multiple chronic conditions that is necessary versus seeing folks in 15-minute increments, et cetera.
What would be the return on investment if we really, really encourage by loan forgiveness doctors to go into primary care?
I remember specifically one meeting that I had with about maybe 15 or 20 medical students at the University of Connecticut. And at some point in the meeting, we were, I think, talking about the Affordable Care Act and how it could help medical students. We were talking a lot about this issue of the high level of indebtedness. And I asked them how many of you are considering, not committed to, but considering going into primary care. And of the 15 students around the table, one of them raised their hand. Only one was even considering it. I hope that that's part of our hearing as well today, is how do we put the practice of medicine back into primary care?
We hope that one of the goals is that everyone has that primary care doctor, that quarterback in their life who can treat them, but also get them access to specialists and the best care.
I think this is a critical issue facing our country today. I know that in my state of North Carolina, we have more than 1 million people who don't have access to primary health care because of a shortage of providers. What happens when they don't have that access? They go to the hospital, and that's where emergency care and treatment is so expensive.
Hearings like this that point out that there really is a problem with cost and with the delivery system in the United States, and that we really have to address that problem if we're not going to misdiagnose what we have. And once, of course, you know you have a misdiagnosis, you usually don't get the right cure either.
I had the privilege of working for 12 years at a community health center, Upper Cardozo, part of the Unity Network. It's about 2-3 miles from here. Mm-hmm. And what one saw there, what I saw there day to day, was a population that, were it not for that health center, would be in the emergency room.
By statute and mission, community health centers are located in medically underserved areas and serve medically underserved populations and care for everyone regardless of your ability to pay.
When dealing with the expanded number of patients and the barriers to care for these patients, several components need to be considered. One is the ability for providers to be able to practice to their fullest scope of their education and licensure. Another is addressing the shortage of providers due to retirement and a shortage of qualified faculty to educate new providers.
Currently, we have no planning in place to actually meet the needs of our population in the United States with regard to a physician workforce. Health insurance leads to significant benefits and is good for your health.
Medical schools react very much like everyone else to the money, and I think we just threw the direct graduate medical education and indirect at them without really asking much in return.
Every single day, people without a physician line up across the street from our hospital to be seen in our walk-in clinic. Hundreds of people a week, tens of thousands a year, stand out in the wee hours of the morning, hoping to be one of the 120 to 200 people who will be seen that day. Even better, hoping to be one of the 12 patients who will be assigned a primary care physician and given an appointment so they won't have to come back.
The report that we have done, Primary Care Access, is available at my website, sanders.senate.gov.